Mahaba, and welcome to a brand new episode of The Doc Is In, where Cleveland Clinic Abu Dhabi's expert physicians and dedicated caregivers converge to explore the dynamic intersection of technology, compassionate care, and cutting-edge research that helps deliver the best patient outcomes. My name is Prudence, and I will be your host for today's episode, brought to you by the Fatima bint Mubarak Centre here at Cleveland Clinic Abu Dhabi. Before we dive in, remember to hit like, subscribe, and turn on the notifications button, because we're here to make The Doc Is In your #1 destination for healthcare podcasts. So whether you're about to buckle up for a drive, getting ready for a run, or making a cup of coffee, join us now because The Doc Is In. Here with me on today's episode of Robotics, Surgery in Colorectal Cancer is Dr Shafik Sidani and Dr Faek Jamali. Dr Shafik Sidani is an authored fellowship-trained colorectal surgeon with the Fatima bint Mubarak Centre, section head of colorectal surgery for the Digestive Diseases Institute, and the director of surgery here at Cleveland Clinic Abu Dhabi. Dr Shafik completed his surgical training at Yale University, Georgetown University, and the University of Minnesota. Dr Shafik has over a decade of experience and is a specialist in minimally invasive surgical treatment of colorectal cancer with extensive experience in robotic and sphincter-sparing surgeries for colorectal cancer. Alongside Dr Shafik today is Dr Faek Jamali. Dr Faek is a consultant surgical oncologist with our Fatima bint Mubarak Centre and a colorectal surgeon for the Digestive Diseases Institute. Dr Faek is a specialist in surgical oncology with a strong focus on the management of peritoneal surface malignancies as one of our providers for Faek. Dr Faek's credentials include over 23 years of experience, concurrent fellowships in complex surgical oncology and minimally advanced invasive colorectal surgery, and he spent time as a tenured professor of surgery. So welcome again to today's episode, and welcome to Dr Shafik and Dr Faek. How are we, gentlemen?
Thank you, Prue. It's wonderful. It's good to be here, and we look forward to make this as beneficial as possible.
I'm excited about this one. So on today's podcast, we are going to be discussing robotic surgery in colorectal surgery. And Dr. Shafik is going to be giving us some expertise and great answers today. And Dr. Faek Jamali is going to put him under the buzzer with some great questions.
I will do my best.
You'll do your best.
I will.
All right,
so first of all, I
in.
really wanna welcome my friend, my partner, my colleague, and the director of robotic surgery at Cleveland Clinic Abu Dhabi, Dr. Sidani. I think he has a lot to share with us today, and I really look forward to the questions that we're going to ask. So robotic surgery is something that's come about in the last, I would say, decade or so, and there's a lot of question about it. And so maybe you can introduce us to, robotic surgery, a little bit about the history of robotic surgery, and is it really something, is it hope or is it hype?
So thanks for the introductions, and welcome to the audience to our second podcast here. Everyone knows about the conventional, the traditional, the old-fashioned open surgery we do for colon cancer, rectal cancer, and whatever. And that's a great operation. We still do it sometimes. It's effective, it's successful, complications are reasonable, complication rates, but you end up with a big incision, which is painful. You have complications related to the incision, like surgical site infections, hernias, prolonged recovery, longer return to normal life, longer lengths of stay, and the cost of all that downstream to the system. In the 80s, we started doing laparoscopic surgery. So we started developing, the concept of minimally invasive surgery, which is, less on the outside, but the same on the inside. And so laparoscopy came about in the 80s, and we started using it for colorectal cancer and colorectal surgery more in the 90s and after that. And laparoscopy, or the keyhole surgery, is basically where we, make small incisions, 0.5 centimeter to 1 centimeter. We put a camera in the abdomen after we insufflate or, blow up the abdomen with CO2, with gas. And we have a working space where we insert ports in these small incisions, And we do the same operation from the inside with similar outcomes in terms of the success of the operations and the complication rates, sparing the patient a larger wound, larger incision, and the issues related to that we discussed. So ultimately, the patients recover quicker. They have, they're more satisfied. They have less wound-related or incision-related issues, and their life returns to normal quicker. And it tends to be more cost-effective in terms of to the system. There are limitations to laparoscopy. Those limitations include, these laparoscopic instruments that we use are like straight sticks that open and close at the very end. And so it's difficult to work with these instruments in tight spaces, especially if we go down into the pelvis, which is a confined space, and we talked about that the last podcast. It's confined to the bones in the pelvis, and we're working in tight spaces, trying to get a precise surgery done. Also in laparoscopy, you're limited to a camera which someone has to move, and usually the surgeon is operating with an assistant surgeon, and that surgeon has to work with the operating surgeon to move that camera around to show that the operating surgeon where he's working or she's working. So it kind of has to be a delicate dance between the surgeon and the surgeon's assistant in terms of moving the camera and assisting with the assistant instruments. So with these in mind, robotic surgery was developed. Laparoscopy exploded in the 90s and the 2000s, but it was kind of slower to pick up for difficult operations like rectal cancer. So in the States at least, there was still a lot of surgeons who were doing rectal cancer the old-fashioned conventional open way. And so we kind of were losing the benefit of minimally invasive surgery in terms of the public with laparoscopy and the technical difficulties associated with it. So robotic surgery came along, and it aimed to address some of these technical difficulties of laparoscopy. So when we talk about robotic surgery, patients especially tend to think it's an automated robot, but we haven't gotten to that point yet. It's basically robot-assisted surgery, we call it. And what we do is it's similar to laparoscopy in terms of being minimally invasive. We make small incisions a similar way, and we put ports in where we put instruments in that. And we operate with a camera with long instruments, but instead of the surgeon using these instruments and operating them, these instruments are attached to a robotic platform, including the camera, and then the surgeon, the operating surgeon, operates the robot from a console. So there's a console that where the operating surgeon sits, which is just next to the patient in the operating room, and the operating surgeon kind of like a video game moves the surgical instruments in the patient's abdomen, or in the chest for thoracic surgeons or cardiac surgeons. And so how did robotics address some of these technical difficulties of laparoscopy? First of all, the camera now is being driven by the operating surgeon. So there's not an assistant surgeon required to follow the surgeon around where he or she is working. The surgeon is actually moving the camera, and so that's easier for the surgeon. And when it's easier for the surgeon, it's always better for the patient. The other thing the robotic platform allows for technically is the instruments, when compared to the laparoscopic straight stick instruments, are wristed. And so you have this range of motion in terms of the instrumentation where you can work in tight areas, behind certain things, tight angles, and that helps us with some of the more difficult operations in difficult spaces like the pelvis, or in types of surgery where precision is required, like the pelvis for rectal cancer. And sometimes even with technically difficult operations, so patients who are obese, patients who have had previous operations and adhesions, and it's reoperative surgery, the robot can help us with this wristed instrumentation. And with laparoscopy, we're kind of limited with these types of patients, these difficult operations. With robotic surgery, we're able to accomplish many of these difficult operations, redos, obese patients, tight areas, pelvis. We're able to accomplish that minimally invasively, whereas with laparoscopy, we would have to convert to the conventional open surgery. So the other technical advantages that it adds to laparoscopy is, all surgeons, they claim, or they may claim, that they don't have tremor, but there's a certain amount of physiologic tremor in surgeons' hands, and the robot eliminates that. So it eliminates the tremor because the platform is controlling the instrumentation controlled by the surgeons. So all of that gives us certain technical advantages. In addition to it being more ergonomic for the surgeon, it gives us technical advantages over laparoscopy to allow us to accomplish difficult operations minimally invasively, and therefore all the downstream effects of that are, the advantages of minimally invasive surgery. Smaller wounds, quicker recovery, lower length of stay, less wound complications, and quicker recovery, quicker return to normal life for the patient.
Wonderful. That was really brilliant. So let's talk a little bit about where we left off, where you suggested, which is, yes, we have advantages with robotic surgery. Let's be a little bit more specific. So for example, let's begin with colon cancer, and then we'll address rectal cancer. So let's begin with colon cancer. So if you're doing a right colectomy or a left colectomy, laparoscopic versus robotic, a lot of surgeons out there will argue that the robot adds little value to a case like this, and then they could do an equally good job laparoscopically. Well, what do you think to that? What would be your idea of what the potential advantages of robotics would be in this particular scenario?
That's a great question, and something we debate all the time, in the colorectal surgery societies. But I think robotic surgery is here, and it's here to stay. And the reason it's here to stay is that it kind of levels the playing field technically. So for expert colorectal surgeons who do laparoscopy regularly, I think in colon cancer, most of us can do an equally good operation laparoscopically or robotically for colon cancer. In terms of oncologic outcomes, success rates, complications, and so forth. What the robot adds, I think, is something we mentioned earlier, is for the difficult cases. So when you have cases that are difficult that may lead to conversion from laparoscopy to open surgery, so redos, reoperations, adhesions, obese patients, large tumors, these kinds of difficult operations are usually tackled better technically with the robot, and you're less likely to have a conversion to open conventional surgery with the robot. The other thing is, laparoscopically, let's take right colectomies. So in expert laparoscopic hands, colorectal surgeons, many can do a good resection, an intracorporeal anastomosis, a fanning steel incision, and the patient does well in terms of wound complications. Many colorectal surgeons aren't able to do intracorporeal anastomoses or do them well or are comfortable doing them. So what they end up doing is they do a laparoscopic approach, and then they make a small midline incision, which is more prone to having incisional hernias, and they do their anastomosis extracorporeally. And so what the robotic platform allows is for these surgeons to be able to kind of in an easier way do a intracorporeal anastomosis with the downstream effects on wound complications. And so it's more applicable to the to the general expertise levels of colorectal surgeons in the community. So I guess it levels the playing field in terms of the level of ability in laparoscopy. It makes it easier to do minimally invasive surgery for these patients. So what does the data show? Pretty much that kind of thing, that you're better able to do intracorporeal anastomosis, and so your hernia rates can be lower. In terms of oncologic outcomes, they're pretty similar for laparoscopy and robotic surgery from the data we have. And now kind of with the popularity uptick in complete mesocolic excision for right-sided colon cancers, and the precision of surgery needed around the vasculature of the transverse mesocolon and right-sided colon mesentery. I think the robotic platform is becoming more popular for that because it allows us to do that better in most hands. So it's more applicable than laparoscopy, I think. So basically for colon cancer, I think it broadens our ability to offer patients minimally invasive surgery when they may have otherwise been converted from laparoscopy to open surgery in many hands. Arguable, but I think that's pretty much understood.
I cannot agree more. I think, as you mentioned, it facilitates complete mesocolic excision. It makes your surgery, it takes away the assistant, it makes you in control of your own field of view and your 3D imaging and all the benefits that come along. So in my mind, I think it is an expensive tool, but it's a tool that will, as you said, exactly level the playing field. So elevate everybody to, I think, a higher level, and it's a great summary. So how about rectal cancer? I mean, I think when we come to the pelvis, the robot is a whole different game here, and some may argue that perhaps you could do an equally good laparoscopic or robotic right colectomy or left colectomy. But I don't think anybody can argue that you could do an equally good laparoscopic or robotic pelvic resection or rectal cancer resection. So can you talk us a little bit through that?
Yeah, I think the gold in terms of colorectal cancer and colorectal surgery for the applicability of robotic surgery is in the pelvis. We discussed this last podcast. You said it well, and that today. The pelvis is a tight area, and we're trying to take out a tumor in a technically very, critical area for rectal cancer. And so the robotic platform is perfect. All the advantages we discussed a few minutes ago apply really well for rectal cancer. Last podcast you talked about this a lot. The rectum, the technique of doing a TME, a complete TME, the circumferential resection margin and the importance of that oncologically, the importance of distal margin, that all comes to play. And we can do a good open rectal cancer surgery, but I think in terms of laparoscopy, in most hands, it's not as it hasn't been able to been reproduced as well, I think. And some studies show that, some don't, in terms of comparing laparoscopy to open surgery for rectal cancer. But when robotic surgery came along, I think it allows us to do it better. So around the rectum, most of our audience probably knows this, the innervation going to the sexual organs and the urinary organs are in close proximity to the total mesorectal excision, and I think being precise and doing precise surgery helps avoid the urinary dysfunction and sexual dysfunction that many of our patients end up having if those nerves are damaged. And it's probably underreported in most case series. But being able to see those well with the robotic platform and the 3D camera, being able to operate in these tight spaces with precision with our wristed instrumentation and control the camera ourselves all the way down into the deep pelvis, especially for distal rectal cancers, being able to get an adequate distal margin for sphincter-preserving surgery to avoid permanent colostomies, and being able to just staple way down above the anal canal to spare the sphincter and get a good distal margin. The robotic platform is, I think, really ideal for that. What do the studies show? Most case series suggest a benefit in terms of definitely for the complications of urinary and sexual dysfunction, but also many for oncologic outcomes and the ability to do the surgery minimally invasively. There was a major trial, the ROLAR trial, which compared laparoscopy and robotic surgery for rectal cancer, and it didn't show much of a benefit in terms of conversion rates. But when they took the kind of subgroup analyses of, if you like, the difficult operations, so really the harder cases, then the robotic platform had superior outcomes and the conversion rate to open surgery. So in summary, what the data shows us is that for the difficult rectal cancers, the robotic platform is superior. And so for easy cases, we can do it laparoscopically.
I have yet to meet an easy rectal cancer. That
Right,
is something that is, I think, rare.
Yeah.
Most rectal cancers are challenging and difficult. And
But I mean, anyone who's done rectal cancer surgery laparoscopically and done it robotically will tell you it's much easier, and they do a much better job technically with the TME with a robotic platform than with laparoscopy. And their conversion rates are lower with it. So
I think you hit it right on the head. Conversion rate, that's very important. Outcomes are very bad when you convert. When you're doing something laparoscopically and you convert to open, the oncologic outcomes are much worse. The patient outcomes are much worse. They have a higher rate of complications, bleeding, and what have you. So short-term complications, long-term complications. So conversion is really bad. And some of the trials had a rate as high as 17 or 20% risk of conversion. All of the new data on robotics has a conversion rate that's well below 5%. So I think you hit it on the head. Conversion is a critical factor in rectal cancer surgery, and the robot can help with that. Sexual function, very important, very understated. Urologic function, very understated. Patients, surgeons don't talk about it a lot. Patients don't talk about it a lot because it's an element of shame. So I think those are really critical. And then a little bit about lateral pelvic lymph nodes.
yeah, so the lateral pelvic lymph nodes similar to the concept of distal rectal cancers. Those nodes, they start off easy to see, and then they end up down by the obturator area, difficult to see and fish out. So it's doable laparoscopically. It's actually easier to do it laparoscopic than open, but then when you use the robot for that, it's easier to identify all the vessels and do precision surgery, get all the lymph nodes off the vessels, off the nerve, and go all the way down to kind of get the complete lymphadenectomy of that lateral compartment. So robotically, it's technically significantly easier. I don't know of any data that says that, but it's kind of a newer thing in evolution, and I think eventually we'll get data to see what it looks like.
Great. So one last thing, sphincter preservation with the robot. Can you tell us a little bit more about that?
Yeah, so I think, in the difficult cases, so obese males, tight pelvis, the ones where the ROLAR trial showed it's, a benefit, I think definitely you're going to have a better time, easier time going all the way down and stapling with a good distal margin if you're trying to do that. And to do it well with a good TME, a good oncologically sound resection. Adding a good robotic distal resection with a transanal approach, I think, can be ideal for certain distal tumors that are invading the proximal part of the anal canal, the internal sphincter, and so forth. And so we can really push the boundary much further with robotic surgery.
So it helps you. I mean, do a better job in terms of sphincter preservation. Yeah. Absolutely. I think that's the most important thing. Great. So what are some challenges? I mean, robotics is not all rosy. I'm sure there are challenges. So can you, just fill us in a little bit about some of those challenges?
So absolutely. So it's great, and if it was widely available and cheap, it would be wonderful. Perfect. But the main challenge behind robotic surgery and its adoption, wider adoption, is its cost at this point. So it's an expensive piece of equipment. In general, if you look at most operations we do, at least in colorectal surgery, the cost per case is significantly higher when you compare robotic surgery to laparoscopic surgery. And it was the case when we started doing laparoscopic surgery as well, and that led to many being skeptical about the adoption of laparoscopic surgery, and claiming it was significantly more expensive.
And longer.
And longer, and et cetera, with all the challenges we have now with robotic surgery. But with time, laparoscopy became cheaper. We were able to demonstrate the downstream effects on cost from doing minimally invasive surgery in terms of length of stay, lower complications, lower long-term complications, and that kind of led to it being more cost-effective. Now with robotic surgery, it's still expensive, and with time, I think what happened with laparoscopy will happen with robotic surgery. We're trying to demonstrate more of a benefit when we compare robotics to laparoscopy in terms of downstream effects of length of stay, lower complications, et cetera. So once we can do that, that'll play into the cost effectiveness. I think with more competition in terms of industry to what's available now, I think prices will inherently come down, and that will help prices come down and it be more competitive in the market. The other challenge, I think, besides cost is its learning curve. So it's another tool that surgeons have to learn. Surgeons learn open surgery, they learn laparoscopic surgery, and now there's another platform to do it in another way, which is robotic surgery. And so it does require a learning curve. It's different than laparoscopy. Once you get the hang of it, it's easy to learn even for open surgeons. But the learning curve does take a while, and during that learning curve, it can cost more to the system. It can take longer, and so providers should be cognizant of that. That's one of the kind of, surgeons have to go through the learning curve and go through it in a responsible fashion, keeping in mind the resources available to them. So in summary, it's basically another tool we can use. It's not going to make us better surgeons, but it may allow us to do more things minimally invasively, and that may have some cost benefit.
And I think you've alluded
downstream.
to a very important point, which is that a lot of open surgeons can transition directly to robotics.
Yeah, absolutely.
Which is something that you really can't do with laparoscopy. So I think this is also one of the advantages. Perfect. So you hit a little bit on it, but let's delve into the future. So close your eyes, go 10 years to the future. Where do you see robotics, and where's current research going into, in what direction, and where do we potentially see robotics shining or doing much better?
Yeah, this is a lot of exciting stuff in the pipelines that we hear about. Whenever we talk about robotic surgery, the first thing you think about is automated surgery, but we're not there yet. But there's certain things coming through in the pipelines are endorobotic surgery, so being able to do robotic surgery endoscopically, for esophageal, gastric, for upper GI stuff, and for colonic and rectal stuff. So there's a lot of exciting stuff coming through the pipelines to allow us to do more stuff intraluminally, so intraluminal surgery robotically. There's a lot of excitement about integrating imaging with robotic surgery. So this can be important in certain types of operations like rectal cancer surgery, where circumferential resection margin is important, where you base a lot of your surgery on preoperative imaging. And so if you can integrate what's happening in surgery in terms of the anatomy that you're seeing with the preoperative imaging and kind of overlap those in terms of like the MRI, for example, then you can do kind of more precision, more tailored, more individualized surgery for that particular patient based on their preoperative imaging. That's really exciting, especially for rectal cancer, maybe for CME as well in terms of the vasculature, etc. The other thing I think is machine learning is becoming a very, very popular thing, and that's happening quickly. Machine learning and AI, etc. And so, the ability of one surgeon to learn from his or her mistakes and from the mistakes and successes of him or herself and the surgeons around them is one thing, but the ability of a robot to learn from all other robots and all other surgeons all around the world is exponentially more significant. And so if a machine can learn all the different variations in anatomy, all the different variations in terms of the operations and the steps of the operation, and can help the surgeon in their doing the operation and the steps of the operation and the anatomy and the variation, that can really change things. And lastly, I think is automated surgery. We've seen some videos of certain things in development of a TME being done by a robot, completely automated, and the speed at which that can be done. We're absolutely not there yet. We still have our jobs right now. But what happens in 10 years, who knows? Things are changing quickly.
The men behind the robot are safe.
For now.
I have a question, and thank you so much. Your answers have been wonderful. As providers, do you see patients? I think they're definitely in a world now of being more educated and having knowledge at their fingertips as far as their treatment plans and what they want. As providers, do you see an increase in the uptake of patients asking for minimally invasive surgery, particularly robotic surgery?
Yeah, what do you think, Faek? What are you seeing in our practice?
Absolutely. I mean, I can remember when we first started using the robot 5-10 years ago, when you would tell a patient that they were going to have robotic surgery, they would be worried. What is this robotic surgery? What is this machine?
Are you doing it?
Are you experimenting on me? Is this something new? Those questions are just not there today. I mean, I tell the patient we're doing robotic surgery, and they're usually, that I like that. That's a good idea. Let's go for it.
Yeah.
So I think there's been a lot more awareness that robotics are beneficial, that robotics are actually not harmful. That's been demonstrated. And I think there is public awareness and public acceptance. So we don't have to sell it anymore. We don't have to convince the patient that robotics are better. And in many cases, like you mentioned,
they're looking
for it. Absolutely, they're looking for it. And if you look at the United Arab Emirates or Abu Dhabi, there are 2 or 3 robots in town. There aren't that many. And so if you really want to have your surgery done robotically, you can only go to one of those 2 or 3. Absolutely.
Yeah, patients come and ask for it now.
Yeah.
Even physicians are referring patients because you do specifically robotic surgery. So it's become a thing and people want it now. And doctors who are patients want robotic surgery done. So especially for rectal cancer, people come, they want robotic surgery, and understandable because I think they're learning about the advantages of it. And we're fortunate enough that we have it here and we have the expertise, and we're trying to make it as cost effective as possible to the system. So, and we have a good program here.
As you mentioned, I think time will be quite friendly to robotics. As time goes on, costs come down, organizations realize that there is flow-on costs and back-end costs.
So with time it'll get cheaper, and with time the technology will get better. And I think the future, the possibilities of the future are just exciting and endless.
There'll be uni students out there having to be the people that are going to learn to fix them, though. That'll be the next job. Well, any additional questions today on robotic surgery for colorectal cancer, specifically rectal cancer? Anything you'd like to add for our listeners?
I think we covered it.
Covered it?
Yeah.
To our listeners, thank you so much for joining us today. Again, we have Dr. Shafik Sidani and Dr. Faek Jamali here. If you are a provider or you would like to refer to one of our fabulous men behind the robot, please www.clevelandclinicabudabi.ae. You can refer a patient there. Their Find a Doctor pages are also on the website for you. As mentioned, we have got another podcast which was specifically on rectal cancer. So please pop along and listen to that one as well. And most importantly, thank you again for joining us here here on The Doc Is In. It was a pleasure having you.